There is a photograph taken in the summer of 1918, somewhere in a mid-sized American city. The exact location has been debated by historians, though the image itself is not disputed. It shows a street scene, ordinary in almost every visible way. People walking, storefronts open, a trolley car in the background, children near the curb. The kind of photograph that, if you encountered it in a family album without any context, you might look at for 3 seconds and move on. What the photograph does not show, what no photograph from that summer could show, is what was already moving through the air around those people. Already in the lungs of some of them, perhaps. Already traveling, silently and without any announcement, through the ordinary fabric of American daily life. Within months of that photograph being taken, more Americans would be dead than died in combat in both world wars combined. The streets in that image would empty. The storefronts would close. The children near the curb would grow up in a country that had been, in the most literal sense, hollowed out, and would then, with a speed that seems almost indecent in retrospect, simply decide not to talk about it. This is the story of what happened to the United States after the worst epidemic in its modern history. Not just during the crisis. That part is documented, if not widely known, but after. In the weeks and months and years and decades that followed. The ways a country changes when it loses hundreds of thousands of people in the span of a few seasons. The ways it sometimes doesn't change, when it probably should. The ways it remembers, and the extraordinary ways it chooses to forget. It is, in some respects, the most consequential story in American history that most Americans were never told. To understand what the flu did to America, you need to understand what America was in the months before it arrived. The summer of 1918 was a particular kind of American moment. The country had been in the First World War for just over a year, since April of 1917, and the initial hesitation of a nation that had spent 3 years watching Europe destroy itself from a comfortable distance had transformed, through a combination of genuine outrage and extremely effective government propaganda, into something closer to full national mobilization. Factories were producing war material at a pace that was reshaping the industrial landscape. Young men were training in military camps across the country, preparing to join the American Expeditionary Forces in France. War bond drives filled public squares. Patriotic rallies drew large crowds. The country was, in the terminology of the moment, united. It was also, in ways that would matter enormously over the coming months, very crowded. The wartime industrial boom had drawn enormous numbers of workers into cities and factory towns, filling housing that was already inadequate before the influx. The military camps where hundreds of thousands of soldiers were training were, by the standards of any public health consideration, extraordinarily dense environments. Men sleeping in close quarters, eating together, training together, sharing the air of barracks and mess halls in conditions that any epidemiologist would look at today with something close to alarm. American medicine in 1918 was considerably more capable than it had been a generation earlier. The germ theory of disease, the understanding that infectious illness was caused by specific microorganisms rather than bad air or moral failing, was by now firmly established. Hospitals had improved enormously over the previous 50 years. Surgical technique, antiseptic practice, the training of nurses, all of these had advanced in ways that made early 20th century medicine recognizably modern compared to what had existed before the Civil War. but there were also enormous gaps. Antibiotics did not yet exist. Penicillin was still a decade away from Alexander Fleming's famous accidental discovery, and the development of usable antibiotics for clinical treatment would not happen until the 1940s. Viruses, as a distinct category of infectious agent, were only beginning to be understood. The influenza virus itself would not be isolated and identified until 1933. In 1918, the doctors and public health officials who would face the epidemic did not know what caused it. They did not know how it spread with such devastating efficiency. They did not have any specific treatment for it. They had supportive care, rest, fluids, nursing, and the ability to treat some of the secondary bacterial complications that killed many of the flu's victims, but they had nothing that addressed the underlying infection. This was not, at the time, considered a particularly alarming gap. Influenza was understood as a serious illness, uncomfortable and sometimes fatal, but manageable. Seasonal flu came every year. People got sick. Most recovered. The elderly and the very young were most at risk. This was the established medical understanding of influenza in the summer of 1918, and it was about to be comprehensively overturned. The country entering the fall of 1918 was confident in a way that had a particular quality, the confidence of a nation that believed it was winning a war, that believed its institutions were fundamentally sound, that had not recently been forced to confront the limits what its medical and governmental systems could actually handle. That confidence was not entirely unjustified. The United States in 1918 was, by many measures, a powerful and capable country. It was also, in ways it did not yet know, completely unprepared for what was about to happen to it. The name is wrong. This is one of the first things worth establishing, because the name has shaped how the epidemic has been understood and remembered, and the way it got attached to a country that had almost nothing to do with the virus's origin is itself a small lesson in how information moves during a crisis. The influenza pandemic of 1918 did not originate in Spain. Spain did not have an unusual burden of the disease compared to other countries. What Spain had, uniquely among the major nations involved in or adjacent to the First World War, was a free press that was not subject to wartime censorship of health news. When the epidemic began causing significant illness in Spain in the spring of 1918, including, notably, a serious illness in King Alfonso XIII that received considerable press coverage, Spanish newspapers reported it openly and in detail. The warring nations, the United States, Britain, France, Germany, were censoring information about the epidemic because reporting mass illness among their populations and military forces was considered bad for morale. Their newspapers did not report it, or reported it minimally and without alarming detail. The result was that the international coverage of the epidemic in those early months came primarily from Spain. And the epidemic became, in the international imagination, a Spanish problem. The Spanish flu. The actual origin of the 1918 strain is still debated among historians and virologists. The most widely discussed early cluster is at Camp Funston in Kansas, where an early wave of influenza in the spring of 1918 caused significant illness among soldiers. Some researchers have pointed to earlier cases in other American locations. Others have argued for origins in Europe or China. The honest answer, more than a century later, is that the precise geographic origin of the 1918 H1N1 influenza strain is not definitively established and may never be. What is established is what the virus did when it reached human populations in large numbers, and why it was so different from the influenza that people were accustomed to experiencing. The 1918 influenza killed in patterns that were deeply strange to the physicians observing it. Influenza, in its normal seasonal form, kills primarily the elderly and the very young, the immunologically vulnerable at both ends of the age distribution. The 1918 strain killed people in those categories, certainly, but it also killed, with particular ferocity, young adults in the peak of their health, people between roughly 20 and 40 years old. The mortality curve, when plotted against age, showed a characteristic W shape, with peaks in the very young, the very old, and the 20 to 40 age group in the middle. This age distribution is what made the 1918 flu so catastrophically different from anything that had come before, at least within living memory. Young, healthy adults, the soldiers in the military camps, the factory workers, the parents of young children, were dying not at the margins, but at the center of the mortality pattern. The mechanism behind this unusual age distribution has been the subject of scientific investigation for decades. The most widely accepted explanation involves what immunologists call a cytokine storm, an overreaction of the immune system in response to the novel viral strain, in which the immune response itself becomes catastrophically damaging to the body's own tissues. A stronger, more robust immune system, the kind a healthy young adult has, may, in this specific context, produce a more severe cytokine storm than an older or younger person's immune system would generate. The very thing that normally protects young adults may have, with this particular virus, been contributing to their deaths. The clinical progression of severe 1918 influenza was something that doctors and nurses who witnessed it described consistently and with obvious horror. A person could be apparently well in the morning and dead within days. In severe cases, the lungs filled with fluid. Cyanosis, the bluish discoloration of the skin caused by inadequate oxygenation, appeared in cases severe enough that some physicians, encountering it for the first time, initially questioned whether they were dealing with influenza at all. The scale of the suffering, and the speed with which it developed, was unlike anything in the contemporary medical experience of people trained in the late 19th and early 20th centuries. The first wave of the 1918 pandemic moved through the United States in the spring of 1918, causing significant illness but somewhat lower mortality than what was to come. It was the second wave, arriving in the fall of 1918, beginning roughly in September, that was catastrophic. More transmissible, apparently more lethal, it swept through the population at a speed and with a mortality that overwhelmed the medical systems of affected cities within weeks. It is the fall wave that defines the 1918 pandemic in memory, to the extent that it is remembered at all. And the story of how American cities encountered it tells you a great deal about the country those cities existed within. Philadelphia holds a specific and uncomfortable place in the history of the 1918 pandemic in America, and understanding why requires understanding the particular pressures on American cities in the fall of 1918. By late September of that year, public health officials in Philadelphia were aware that influenza was spreading in the city. Cases were being reported. The pattern was recognizable to anyone paying attention to what had already happened in military camps and in other cities. Dr. Wilmer Cruson, the city's director of public health, was among those who understood what the data was suggesting. He allowed the Liberty Loan Parade to proceed as scheduled on September 28, 1918. 1918. It was a large parade, a war bond drive event, the kind of patriotic public gathering that had become a feature of American urban life during the war years. Hundreds of thousands of people lined the streets of Philadelphia to watch it. They stood close together in the cool fall air for hours. Within 72 hours of the parade, every hospital bed in Philadelphia was occupied. Within a week, the city's medical system was in a condition that its own officials described as collapsing. The dead were accumulating faster than they could be buried. The city's coffin supply ran out. Emergency morgues were established in locations that had not previously served that function. Priests moved through the streets on carts, collecting the dead. Philadelphia's experience was, in quantitative terms, among the worst of any American city. The death rate in the weeks following the parade was staggering. And the parade decision has been analyzed and reanalyzed by historians and public health researchers in the century since, because it represents, with a particular clarity, the collision between the two imperatives: the public health imperative to prevent mass gatherings during an epidemic, and the wartime political imperative to maintain morale and keep the bond drives running, in which the political imperative won, and the consequences were catastrophic. Not every American city made the same choice. And this matters because it created a natural comparison group that public health researchers would later analyze with considerable interest. St. Louis, Missouri, is the city most often cited in contrast to Philadelphia. When influenza arrived in St. Louis in early October 1918, the city's health commissioner, Dr. Max Starkloff, moved quickly. He closed the schools. He banned public gatherings, churches, theaters, dance halls. He implemented a system of staggered business hours to reduce crowding on streetcars. He did all of this rapidly, before the epidemic had fully taken hold in the city's population. The results were measurable. St. Louis's peak death rate during the 1918 pandemic was roughly 1/8 of Philadelphia's peak death rate. Not zero, no city avoided the epidemic, but dramatically lower than in cities that moved slowly or not at all. The difference was significant enough that public health researchers in subsequent decades held up the St. Louis response as evidence that non-pharmaceutical interventions, the closing of schools, the banning of gatherings, the reduction of contact between people, could meaningfully slow the spread of influenza. This comparison would be rediscovered, reanalyzed, and cited extensively during the early months of the COVID-19 pandemic in 2020, when public health officials looking for historical guidance returned to 1918 and found, waiting for them, a remarkably well-documented case study in what works and what doesn't. The lesson had been available for a century. It had just been largely forgotten. Other American cities made other choices, with outcomes that reflected those choices. San Francisco implemented mask mandates, an imperfect measure, since the cloth masks of 1918 were not well suited to blocking viral transmission as we now understand it, but one that reflected an attempt to respond. Denver, Chicago, New York. Each city navigated its own version of the tension between public health necessity and the social and economic disruption of closure, and each paid a different cost depending on when and how decisively it acted. The federal government's response was shaped, throughout, by the peculiar constraints of a wartime administration. Woodrow Wilson, occupied with the conduct of the war and the diplomatic maneuvering surrounding the eventual peace, made no major public statement about the influenza epidemic during the worst months of the fall wave. The war was the priority. The epidemic was, in the government's public communications, something that existed at the margins of official attention. This reticence was not purely negligence. There were genuine concerns, probably legitimate ones in the context of the time, that openly acknowledging the scale of the epidemic would harm morale and potentially compromise military recruitment and the conduct of the war. The censorship apparatus that had been constructed to manage wartime public information was repurposed, at least partially, to manage information about the epidemic. The consequence was that ordinary Americans, in many cases, received public health guidance that was delayed, incomplete, or actively misleading about the seriousness of what was happening. This would have consequences not just during the epidemic itself, but in the years and decades that followed, in the form of a public distrust that was, given the circumstances, not entirely without foundation. The apparatus for controlling information in the United States during the First World War was more developed than most Americans realize, and it reached into the influenza epidemic in ways that shaped the public's experience of the crisis in significant ways. The Committee on Public Information, established in April 1917 under journalist George Creel, and commonly known as the Creel Committee, was the federal government's primary propaganda and information management agency during the war years. Its mandate was the management of American public opinion in support of the war effort, and it pursued that mandate with considerable energy and sophistication. The Creel Committee produced posters, pamphlets, newspaper articles, and films. It organized a network of volunteer speakers called 4-Minute Men, who gave brief patriotic addresses in movie theaters and public venues across the country. It coordinated, with varying degrees of formality, the editorial decisions of American newspapers. The Espionage Act of 1917 and the Sedition Act of 1918 created legal penalties for speech deemed to undermine the war effort, a broadly drawn category that could, in the hands of zealous prosecutors, encompass almost any critical commentary on government policy or the national situation. Americans were prosecuted and imprisoned under these acts for remarks that would barely register as controversial by modern standards. In this environment, newspapers were cautious. Editors, who might have been inclined to report the full scale of the epidemic as it developed, understood, with varying degrees of explicitness, that certain kinds of reporting were unwelcome. The military's illness and mortality statistics were not publicly released in a form that would have conveyed the epidemic's true severity. The reports that did appear in many newspapers were shaped by a combination of genuine uncertainty about the disease, genuine concern about panic, and genuine pressure to maintain the wartime information posture. The result was a significant gap between what was happening and what Americans were being told was happening. In Philadelphia, in the days before the September parade, public health officials were warning internally of serious epidemic risk. The newspapers were not conveying that warning with anything close to the urgency the data would have supported. Ordinary Philadelphians making decisions about whether to attend the parade had access to information that substantially underrepresented the danger. Surgeon General Rupert Blue issued public advisories about influenza during the fall of 1918. He was not entirely silent, but the advisories were calibrated to avoid alarm, and the guidance they offered was often of limited practical utility, given the constraints of what 1918 medicine could actually do. Wash your hands. Avoid people who are coughing. Seek medical attention if you feel unwell. These are not wrong instructions. They are simply, in the face of a rapidly spreading viral pandemic, moving through a dense, mobile, wartime population, not remotely sufficient. The local responses varied in ways that depended heavily on the character and priorities of local officials. Some city health commissioners moved aggressively, as Starkloff did in St. Louis. Others were more cautious, more deferential to economic and social pressures, more worried about the disruption that closures would cause than about the epidemic those closures might prevent. The federal framework for coordinating a national public health response was, by modern standards, rudimentary. The Public Health Service existed and was functional, but its authority and resources were not adequate to the scale of what was occurring. This institutional inadequacy, the gap between the scale of the threat and the capacity of the government's public health apparatus to respond, would be one of the epidemic's most consequential legacies. Not immediately. The immediate aftermath of the epidemic saw, in many quarters, a return to normalcy and an active impulse to move on, rather than to analyze and reform. But the longer institutional memory of what 1918 had revealed about American public health capacity would gradually, fitfully, and incompletely shape the development of that capacity over the following decades. In the meantime, the government had told people less than they needed to know. And some of those people had paid for that with their lives. That is a historical conclusion rather than a political one. It is simply what the evidence shows. Whatever the failures of policy and communication, there were people in the fall of 1918 who showed up. Every day, in conditions of overwhelming demand and genuine personal danger, they showed up. The nurses, in particular, deserve a specific and sustained acknowledgement, because their role in the 1918 pandemic has been disproportionately absent from the historical record relative to its actual importance. The doctors who treated influenza patients in 1918 were working without effective tools, without antivirals, without antibiotics, without the specific medical interventions that might have meaningfully changed outcomes for the severely ill. What they could offer was clinical management, supportive care, and the comfort of professional attention. In many cases, this was not nothing. Secondary bacterial pneumonia, which killed many influenza patients, could in some cases be influenced by good nursing care, by keeping patients warm and hydrated and positioned to facilitate breathing. The nurses were the people providing that care, around the clock, in conditions that become difficult to read about calmly even a century later. Hospital wards that had been designed for one patient per bed were receiving 3. Schools and other public buildings were converted into emergency hospitals, and nurses moved between patients in spaces that were not designed for medical care, without adequate supplies, with limited staff, in environments where the patients around them were dying with a regularity and speed that would have been extraordinary, even in a wartime field hospital. Some nurses wore masks, some wore gloves. The infection control knowledge of 1918, even in the best-equipped facilities, was not adequate to reliably protect people caring for severely ill influenza patients. The nurses got sick. Some of them died. They came back to work when they recovered, in many cases before they had fully recovered, because there was nobody else. The accounts left by surviving nurses describe a period that sits in memory not as a continuous narrative, but as a series of moments. The specific faces of patients who died, the specific helplessness of not having the medicine that might have helped, the specific exhaustion of working days that did not end when a shift was supposed to end, because the shift, after yours, had nobody to work it. The Red Cross organized emergency nursing recruitment during the fall wave, attempting to mobilize additional trained nurses and nurses' aides to supplement the overwhelmed professional nursing workforce. Volunteers came forward. Some had genuine nursing training. Many did not, and learned what they could in the situation they found themselves in. The community of women who made up the voluntary nursing effort in 1918, largely invisible in subsequent historical accounts, was doing, in many cases, genuinely heroic work under conditions that have never been adequately honored. The physicians managing the medical response operated with a clinical uncertainty that added another layer of difficulty to an already impossible situation. They did not know the cause of the disease. The dominant theory in much of the medical community in 1918 attributed influenza to a bacterium, Pfeiffer's bacillus, now known as Haemophilus influenzae, which had been identified in previous influenza patients and which many researchers believe to be the causative agent. Vaccine preparations based on this organism were rapidly produced and administered during the 1918 pandemic. They did not work against influenza, because influenza is caused by a virus, not by Pfeiffer's bacillus. The bacterial preparations may have offered some marginal protection against secondary bacterial complications, but they did nothing against the primary infection. Working without a correct understanding of what you are treating, in conditions of overwhelming patient volume, with colleagues falling ill around you, with family members of the dead asking questions you cannot answer. This was the professional reality of American medicine in the fall of 1918. The doctors who wrote about it afterward did so with a characteristic restraint that was partly professional culture and partly, one suspects, the difficulty of finding language adequate to what they had witnessed. A physician named Victor Vaughan, who had been one of the senior military medical officers managing the epidemic response in army camps, and who would later become a major figure in American public health, wrote in his memoirs about visiting Camp Devens in Massachusetts during the worst of the fall wave. Camp Devens was one of the most severely affected military installations in the country. Vaughan described what he found in terms that are measured in their language and devastating in their substance. Young men, healthy men, in extremis, the pace of death in the hospital ward, the exhaustion and distress of the medical staff, and his own conclusion, which he stated with a directness that is striking even now, that if the epidemic had continued to spread at its early pace, civilization as it existed could have been extinguished within weeks. That is not the observation of a man prone to exaggeration. Vaughan was a careful scientist. He was describing what the arithmetic of the epidemic's early trajectory implied, if it had continued unchecked. It didn't continue unchecked. The epidemic did eventually recede, as epidemics do, for reasons that are not entirely understood even now. But the fact that a senior American physician, looking at the data in real time, reached that conclusion tells you something about what those weeks actually felt like from the inside. The epidemic receded, slowly, unevenly, with a third wave in the winter and spring of 1918 that added to the total mortality. The hospitals began to empty. The emergency wards in schools and community buildings closed. The nurses went home, those who had homes to go to and who were well enough to go. And America, which had been through something that had no real precedent in its modern history, began the complicated process of figuring out what came next. That process was stranger and more revealing than almost anyone who participated in it could have known. There is something quietly unsettling about the way the 1918 pandemic sits in the American historical record. Not absent, exactly. The documents are there. The mortality tables, the hospital reports, the newspaper accounts, the letters written by people who were frightened and by people who were grieving. The evidence of what happened is extensive and in many places heartbreaking. What is unsettling is what surrounds that evidence. The silence after it. The speed with which a country that had just lost hundreds of thousands of people in the space of a few seasons from a single cause turned its attention elsewhere and kept it there for decades. The almost complete absence, in the cultural and political life of the 1920s, of any sustained public reckoning with what the epidemic had done. Other catastrophes get monuments. They get anniversary commemorations. They get taught in schools, worked into literature, carried forward in the national conversation as reference points for who the country is and what it has been through. The Civil War, the Second World War. These events left permanent marks on the American imagination. The 1918 flu left almost none. And understanding why, understanding the mechanics and the psychology of that erasure, is in some ways more interesting and more instructive than the epidemic itself. But before the forgetting, there was the dying. And the dying deserves its full accounting. Numbers, when they get large enough, stop functioning as numbers in the ordinary sense. They become something closer to abstractions, figures you can state, figures you can compare, but figures that resist the kind of emotional comprehension that smaller numbers allow. The death of one person is a story. The death of 1,000 people is a statistic, in the sense that the statistician's formulation implies. The death of hundreds of thousands of people is something that the human mind approaches obliquely, through examples and proxies and representative fragments, because it cannot be held all at once. Approximately 675,000 Americans died from influenza and its complications during the 1918 pandemic. That is the figure most widely cited by historians, though some estimates run higher, and the difficulty of precisely counting influenza deaths in an era before standardized death certification makes any figure an approximation. What is not in dispute is the order of magnitude. 675,000 deaths in a country whose total population was approximately 103 million people at the time. That is a mortality rate of roughly 0.65% of the entire population, dead from a single cause in roughly 2 years. In a population the size of the contemporary United States, that proportional mortality would correspond to something in the range of 2 million deaths. The comparison with military casualties is one that historians reach for, because it provides a scale reference that most people can orient to. American military deaths in the First World War totaled approximately 116,000. In the Second World War, approximately 405,000. Together, those two wars, the two most catastrophic military conflicts in American history, killed fewer Americans than the 1918 influenza pandemic. The flu killed more Americans than both world wars combined, and it did so not over years of sustained combat, but in the concentrated violence of a few pandemic seasons. These are the national figures. At the community level, the experience was different, sharper, more personal, more visible in its daily texture. In cities hard hit by the fall wave, the impact on daily life was immediate and unmistakable. Philadelphia lost roughly 12,000 people in the month of October 1918 alone. In a city of roughly 1.5 million people, that represented a death toll large enough to affect almost every social network, every neighborhood, every church congregation, every factory floor, every school. The people who survived the fall of 1918 in Philadelphia did not do so in isolation from the deaths around them. They knew people who had died, often multiple people, sometimes many. In smaller communities, the impact could be proportionally even more severe. Rural towns with limited medical resources, far from the emergency hospitals being established in major cities, sometimes experienced mortality that left them with gaps that took years to fill. A small town that loses its doctor to influenza and then loses a significant fraction of its working-age population in the same season is a fundamentally different place from what it was before. The social fabric, the network of relationships, obligations, labor, and mutual support that constitutes a functioning community, is damaged in ways that do not repair themselves quickly. The demographic specificity of the 1918 mortality made its community-level impact particularly acute. The unusual concentration of deaths in the 20 to 40 age group meant that the flu was killing, with disproportionate frequency, precisely the people most likely to be parents of young children, most likely to be the primary economic supporters of families, most likely to be in positions of community leadership and productive labor. The deaths were not concentrated at the edges of families and communities. They were happening at the center. A family that loses a father to influenza in October 1918. A father who is 32 years old, who has 3 children, whose wife has no independent income, is a family in immediate crisis. The economic consequences are not deferred or abstract. They are immediate and severe. How does that family eat? Who takes care of the children? What happens to the house if the mortgage payment cannot be made? These questions, multiplied across hundreds of thousands of families, produced a social welfare crisis that the institutions of 1918 America were not equipped to handle in any systematic way. Private charity, religious organizations, and extended family networks absorbed much of the burden, as they always had in a country that had not yet developed anything like a modern social safety net. But the scale was beyond what those informal systems could fully manage, and the gaps they left were real and lasting for many of the families who fell through them. The orphans produced by the pandemic, children who lost one or both parents, numbered in the tens of thousands, by some estimates, considerably more. Their stories, which we will return to later in this account, represent one of the pandemic's most enduring and least examined legacies. What is important to understand at this point in the story is that the mathematics of loss were not experienced as mathematics by the people living through them. They were experienced as specific absences. A chair at a table that stays empty. A name that comes up and then is carefully not discussed. A neighbor's house with the curtains drawn for weeks. The sound of a child who suddenly has no father, asking a question that nobody knows quite how to answer. Those specific absences accumulated across hundreds of thousands of households into something that changed the country. Not loudly, not visibly, in the way that wars change countries, with monuments and victory parades and histories written by the participants. Quietly, in the texture of daily life, in the decisions made by people who had survived and were now figuring out how to go on. The decisions made by city officials in the fall of 1918. Close or don't close, act early or wait, restrict gatherings or keep the economy moving, created one of the most useful and most analyzed natural experiments in the history of public health. Researchers studying the 1918 pandemic have been examining those decisions and their outcomes for decades. The work accelerated significantly after 2000, when a group of economic historians and public health researchers began systematically analyzing the mortality data across American cities alongside records of when and what kinds of non-pharmaceutical interventions were implemented. Their findings, published in the early 2000s, provided the quantitative foundation for much of what is now understood about the effectiveness of those interventions. The pattern that emerged from this research was consistent and striking. Cities that implemented interventions early, before the epidemic peaked in their population, had meaningfully lower peak death rates than cities that acted late or not at all. Cities that maintained interventions through the full duration of the epidemic wave had better outcomes than cities that relaxed restrictions prematurely, even if they had initially responded well. And cities that implemented multiple interventions simultaneously, school closures, gathering bans, business restrictions, did better than cities that implemented only one or two measures. The findings were not surprising to anyone familiar with the basic epidemiology of infectious disease transmission. Fewer contacts between people means fewer transmission events. Fewer transmission events means slower spread. Slower spread means lower peak burden on the medical system and ultimately lower mortality. This is not complicated. It is, in fact, about as basic as epidemiological reasoning gets. What made the 1918 data valuable was that it provided historical evidence, real-world evidence from a real pandemic in real cities with real measurable outcomes, supporting conclusions that had previously rested primarily on mathematical modeling and theoretical reasoning. The cities of 1918 had, without intending to, conducted a controlled experiment, and the results of that experiment were available for anyone who looked carefully enough at the data. The challenge was that very few people were looking carefully at that data for most of the 20th century. The academic literature on the 1918 pandemic was thin relative to the epidemic's historical importance. The detailed work of reconstructing city-level mortality statistics, correlating them with intervention timing, and drawing rigorous quantitative conclusions was not done until the early 2000s, more than 80 years after the events in question. When it was done, the implications were significant enough that they fed directly into pandemic preparedness planning in the years before 2020. The 2006 report by the Centers for Disease Control and Prevention on community mitigation strategies for pandemic influenza drew explicitly on the 1918 city comparison data. The concept of flattening the curve, slowing the spread of a pandemic to prevent the healthcare system from being overwhelmed, even if the total number of infections eventually remains similar, has its intellectual roots, in part, in the St. Louis versus Philadelphia comparison from 1918. The interventions of 1918 also, inevitably, produced economic and social disruption. Closing schools, theaters, churches, and businesses is not costless. It imposes economic hardship on the businesses that close, the workers who lose income, the families whose routines are disrupted. The officials who implemented these measures in 1918 understood this. Some of them implemented the measures anyway, concluding that the public health benefit outweighed the economic cost. Others did not, concluding the opposite. The economic analysis of the 1918 interventions is more complex than the public health analysis, and the research findings are somewhat more mixed. But one finding from the economic analysis is particularly interesting. Cities that intervened more aggressively not only had lower mortality, they also, in the medium term, had better economic recoveries. The immediate economic disruption of closure was real. But a city that lost fewer of its working-age population to the epidemic, and whose medical system was less overwhelmed, was also a city better positioned to resume economic activity when the epidemic passed. Protecting public health and protecting economic health were not, in the medium term, opposing objectives. They were, in a significant sense, the same objective. This finding has been rediscovered in every subsequent pandemic and relitigated in every subsequent policy debate. The 1918 data was there, available, for anyone who wanted to learn from it. What it took was people willing to look. The 1918 influenza pandemic did not move through American society uniformly. It moved along the lines of the society it was moving through, the lines of race, class, occupation, and geography that structured American life in 1918, and that made some people vastly more vulnerable than others. This is not a feature unique to the 1918 pandemic. It is a feature of almost every epidemic in recorded history. Disease follows poverty. It follows crowding. It follows the absence of medical care and the presence of conditions, inadequate nutrition, inadequate housing, exhausting labor, that compromise immune function and make recovery harder. Understanding the 1918 pandemic without understanding its unequal distribution is understanding only part of the story. The occupational dimension of vulnerability was significant. Factory workers, miners, textile workers, people whose jobs required them to be in close proximity to large numbers of other people in poorly ventilated spaces for long hours, were exposed to the virus in conditions that maximized transmission risk. The wartime industrial boom had filled factories with workers who often lived in adjacent overcrowded housing, compounding the exposure. A worker who spent 10 hours a day in a wartime munitions plant, then returned to a rooming house where 4 people shared a small room, was living in conditions of essentially continuous high exposure risk. Middle-class Americans, who could afford better housing, who worked in less crowded environments, who had more flexibility in their daily routines, were somewhat better positioned, though not immune. The virus crossed class lines. But the severity of outcomes and the access to medical care during illness varied significantly with economic circumstances. The racial dimension of the 1918 pandemic in America is a subject that received relatively little attention from historians for much of the 20th century and has been more carefully examined in recent decades. The picture that emerges from closer historical analysis is, as it tends to be when the lens of race is applied to American history, considerably more complicated and considerably more troubling than the simplified version. Black Americans in 1918 lived under the full weight of the Jim Crow system in the South and under a de facto segregation that, while less legally codified, was no less real in the North. They had less access to medical care than white Americans, a consequence of a healthcare system that was itself deeply segregated. Black hospitals, where they existed, were chronically underfunded. Black patients were routinely turned away from white hospitals or admitted only to segregated wards with inferior facilities. Black physicians, trained in the small number of medical schools that accepted black students, faced systematic exclusion from medical societies and hospital staff privileges. When the influenza epidemic arrived, Black Americans in many communities had less access to the medical care that might have reduced severity and improved outcomes. They were more likely to live in the overcrowded urban housing conditions that facilitated transmission. They were more likely to hold the essential worker occupations, domestic service and transport work, industrial labor, that required continued exposure even when the epidemic was at its worst. The mortality data, where it can be reconstructed from records that were themselves a product of a segregated bureaucracy and therefore not always reliable, suggest differential outcomes in some communities and comparable outcomes in others. A pattern complicated enough that researchers have been cautious about broad generalizations. What is clearer is that the structural conditions faced by Black Americans in 1918 made their encounter with the epidemic harder, and their access to care during it more limited. The response of the Black community to the epidemic is a story that deserves its own telling, and that has been told too infrequently. Black newspapers, the Chicago Defender, the Pittsburgh Courier, and others, covered the epidemic extensively and, in some cases, more honestly than white-owned papers operating under the informal censorship pressures of the wartime period. Black community organizations, churches, and mutual aid societies mobilized to provide care and support in communities where official public health resources were inadequate or inaccessible. Black nurses, who were not, in 1918, permitted to serve in the American Red Cross Nursing Corps because the Red Cross maintained racial segregation in its nursing program, organized independently, providing care in Black communities through Black-led organizations. The exclusion of Black nurses from the Red Cross nursing mobilization during a national health emergency is one of those historical details that is, on reflection, almost too stark to fully absorb. There was a shortage of nurses. There were trained nurses available. They were not used because of their race. People who might have received care from those nurses did not. Some of those people may have died. Working-class white immigrant communities occupied a middle position in the epidemic's social geography. Recent immigrants, many of whom lived in densely populated urban neighborhoods, worked in industrial occupations, and had limited access to English-language public health information, were significantly vulnerable. The public health messaging of 1918 was primarily in English and did not systematically reach communities whose primary languages were Polish, Italian, Yiddish, or any of the other languages spoken by the immigrants who had arrived in American cities in the preceding decades. The unequal experience of the 1918 pandemic is not merely a historical curiosity. It is a pattern that recurs with depressing consistency across epidemic history. The communities most vulnerable to disease are those already vulnerable in other ways, economically, politically, structurally. Understanding this pattern and building it into the design of public health systems and responses was one of the lessons available from 1918. It was a lesson, like several others from that period, that was learned incompletely and forgotten repeatedly in the century that followed. There is a particular quality to the childhood experience of a pandemic that is different from the adult experience, and that leaves different kinds of marks. Adults experiencing the 1918 epidemic had the cognitive frameworks, however inadequate, to understand what was happening. They had lived through other illnesses, other deaths, other crises. They had some reference points, even if those reference points did not really map onto an event of this scale and character. They could read newspapers, talk to other adults, pray in the forms that their faith provided for large suffering. They had, in other words, some means of processing what was occurring. Children had less. A child of 6 or 8 or 10 in the fall of 1918, watching a parent become severely ill, watching the doctor come and go with a face that communicated nothing reassuring, watching a household that normally functioned according to reliable routines suddenly lose its organizing certainty. That child's experience of the epidemic was one of disruption and fear and a kind of helplessness that was not simply a smaller version of adult helplessness. The schools closed in many cities during the fall wave. For children whose domestic situations were stable, whose parents remained healthy, whose households continued to function, this might have been experienced as something like an extended and somewhat frightening holiday. For children whose parents were ill, whose households were in crisis, the closing of schools removed one of the structures that might otherwise have provided some continuity and normalcy. The children who lost parents during the epidemic faced an immediate practical crisis and a longer-term psychological one whose consequences extended well beyond the pandemic months. A child whose father died in October 1918, and whose mother was left with 3 children and no income, was a child whose life trajectory was materially altered. Whether that child stayed in school depended on whether the family could manage without the child's labor or economic contribution. Whether they received adequate nutrition and care depended on what family and community support was available. Whether they were placed in an orphanage, a common outcome in cases where the remaining parent could not manage alone or also died, depended on the specific circumstances of their family and community. The orphanages of 1918 and 1919 received children from the epidemic in numbers that strained their capacity. The scale of orphaning produced by the pandemic has not been precisely quantified. The record-keeping of the period and the diversity of arrangements made for children who had lost parents makes a definitive count impossible. But the impact on the child welfare institutions of the period was real and documented, and it contributed to the policy conversations about orphan care and child welfare that would develop through the 1920s. Beyond the immediate practical consequences, there is the question of what it meant psychologically to grow up in the shadow of that kind of collective loss. The children of 1918, those who were young enough to experience the epidemic as children, who grew up with its absence at the center of their family lives, became the young adults of the 1920s. The relationship between their formative experience of mass death and disruption and the particular cultural characteristics of the generation they grew into is not simple or direct. Human development doesn't work that way. But the idea that growing up counting the empty chairs leaves no mark seems, on its face, implausible. The literature of that generation, the writers who came of age in the 1920s, who produced the work that defined the lost generation in American literary culture, carries a quality that has been analyzed primarily in terms of the First World War. The disillusionment, the sense of hollowness behind social performance, the reaching for pleasure and sensation as alternatives to meaning. These have been attributed, by literary historians, primarily to the experience of the war and its aftermath. The epidemic runs through the same generation's experience, largely unacknowledged in the critical literature. Whether the flu contributed to the particular emotional texture of the lost generation's work is a question that literary history has generally not asked. Perhaps because literary history, like American culture more broadly, found it easier not to remember the epidemic at all. One writer who did engage with the epidemic was Katherine Ann Porter, whose 1939 novella, Pale Horse, Pale Rider, drew directly on her own near-death experience with influenza in 1918, and on the death of the man she loved during that same fall wave. It is one of the few significant works of American literature in which the 1918 pandemic is a direct subject. It is also, as several literary scholars have noted, relatively less well known than it deserves to be, a position that perhaps reflects the general cultural tendency to look away from the epidemic, even when an artist has looked directly at it and made something of extraordinary quality from what she saw. The children of 1918 grew up. They went to work, married, had children of their own, lived through the Depression and the Second World War, and everything that followed. They carried the 1918 epidemic with them, in the ways that formative experiences are always carried, not always consciously, not always in ways that were visible even to themselves. They did not, for the most part, talk about it. The culture around them did not encourage them to. And when they died, in the 1960s and 1970s and 1980s, much of what they carried went with them. The second wave of the 1918 pandemic, the catastrophic fall wave, is the one that dominates historical memory to the extent that the epidemic is remembered at all. It was the worst in terms of mortality and the speed and scale of its impact. But it was not the end. The pandemic did not end cleanly. It did not end with an announcement, a treaty, a specific date that could be circled on a calendar. It ended in the way that epidemics typically end, gradually, unevenly, with continued transmission and continued deaths in communities that thought the worst was behind them. A third wave of influenza moved through the United States in the winter and spring of 1919. It was less severe in most communities than the second wave had been. The population had some degree of acquired immunity from prior exposure, and the virus itself may have evolved in ways that reduced its lethality, though the specific mechanisms of pandemic wave dynamics are still not fully understood, even by contemporary virologists. But the third wave was not trivial. It added to the mortality toll. It affected communities that had, in some cases, come through the fall wave relatively intact, only to face renewed epidemic activity in the winter. The influenza continued to circulate at elevated levels, relative to normal seasonal flu, through much of 1919. The clear boundary between the pandemic and the endemic, between the emergency and the routine, was blurry in a way that made the psychological process of returning to normal life complicated. When was it safe to stop worrying? When could the masks come off in cities that had implemented mask mandates? When could the schools that had closed reopen and stay open? These questions do not have clean answers, and the lack of clean answers created a particular kind of exhaustion and ambiguity in the communities living through the pandemic's long tail. The emergency that had defined daily life for months was slowly, reluctantly, becoming something else. Not gone, just fading. Moving from the foreground to the background of awareness at different rates in different places, with occasional flares that reminded people who had started to relax that the thing was not entirely over. The armistice that ended the First World War had been signed in November 1918, in the middle of the second pandemic wave. The peace brought genuine relief and celebration. In many cities, celebrations that almost certainly accelerated influenza transmission, as people who had been told for months not to gather in crowds went out into the streets to mark the end of the war with all the social contact that celebration involves. The armistice celebrations of November 11, 1918, produced documented upticks in influenza cases in a number of cities in the days that followed. There is something in that sequence of events: epidemic raging, war ending, people pouring into the streets to celebrate, epidemic spreading further. That captures something important about the relationship between human social needs and public health imperatives. People had been frightened and isolated and constrained for months. The war was over. They needed to be together. The fact that being together, in those specific circumstances, carried a real disease risk did not, in the end, override the need. By the spring and summer of 1919, the epidemic was winding down towards something that could, with some uncertainty, be called over. The death rates were returning to something approaching seasonal baseline levels. The emergency hospitals were closing. The public health interventions that had been implemented were being lifted. And then, remarkably quickly, the country began to do something that would characterize its relationship to the epidemic for the next century. It began to look away, not all at once, not consciously in most cases, not through any organized decision or policy, simply through the ordinary human preference for moving forward over looking back, amplified, in this particular case, by a set of cultural and political circumstances that made looking back at the epidemic especially uncomfortable and looking forward especially attractive. Understanding how that forgetting happened and why it happened so completely and so persistently is the subject toward which this story has been building from the beginning. There is a specific kind of silence that follows a catastrophe that nobody quite knows how to talk about. Not the silence of grief, exactly. Grief has its own sounds, its own rituals, its own recognized social forms. This is a different kind of silence. The silence of a thing that happened, that everyone knows happened, that affected almost everyone in some direct and personal way, and that nonetheless fails to find its way into the conversations that shape how a society understands itself. The 1918 pandemic produced that silence in America. And the silence was not accidental. It was, in its own way, constructed, built from the specific materials of the moment, from wartime psychology and political pressure, and the very human desire to put terrible things behind you and get on with whatever comes next. To understand that silence, you have to understand the country that produced it. A country that was simultaneously exhausted by catastrophe and desperate for normalcy. A country that had been told, for months, by its government and its newspapers and its community leaders, not to panic, not to despair, to keep going, to maintain morale, to be strong. A country that had spent more than a year learning to subordinate its private griefs to a public narrative of national purpose. That country was, in a very practical sense, not well equipped to stop and reckon with what had just happened to it. And so it didn't, or not nearly enough. The absence of the 1918 pandemic from American collective memory is, for anyone who encounters it as a historical fact for the first time, almost more surprising than the epidemic itself. How does a country lose a catastrophe of that scale? How do 675,000 deaths, more deaths than the Civil War, more deaths than both world wars combined, fail to produce a monument, a memorial day, a sustained literary tradition, a generation of oral history? The answer is not a single thing. It is several things working together, reinforcing each other, producing a collective outcome that none of them would have produced alone. The first and perhaps most fundamental factor is the wartime psychological context in which the epidemic occurred. Americans in 1918 had spent more than a year learning to think in a specific way about suffering and death, as sacrifices in service of a larger national cause, as things to be endured with stoicism and public optimism, as subjects about which excessive dwelling was unpatriotic. The cultural machinery of wartime morale management had been running at full capacity for over a year by the time the epidemic arrived, and it shaped, inevitably, how the epidemic was processed. Dying of influenza did not fit the available narrative frameworks of 1918. The war provided narrative, sacrifice, heroism, cause, meaning. Soldiers dying in France died for something, in the terms that the culture provided. People dying of flu in Philadelphia died of a disease. There was no narrative framework within which that death was heroic or meaningful in the way that war death was understood to be. The deaths were just deaths, enormous in number, arbitrary in their selection, without the consolation of purpose. A society that had been organized around the production of meaning from military sacrifice had very limited cultural infrastructure for processing the quite different kind of loss that the epidemic produced. And so the epidemic's deaths were, to a significant degree, not processed. They were simply absorbed. added to the total of things that had happened, grieved privately in families and communities, and then, as quickly as possible, set aside. The second factor is the specific role of the press in shaping what the epidemic would become in public memory. The newspapers of 1918 had underreported the epidemic during its worst phases, for the combination of wartime censorship pressure and genuine uncertainty about what was happening that we have already examined. The result was that when the epidemic was at its most severe, when the events that might have been most vividly recorded were occurring, the public record being created was incomplete and, in important ways, misleading. What gets written at the time becomes the first draft of history. If that first draft is incomplete, if the newspapers don't fully capture what is happening, if the official records underrepresent the mortality, if the individual accounts are not collected or published, then the historical memory that develops from those sources is also incomplete. The gaps in the contemporary record became gaps in the historical record, and those gaps made it easier, in subsequent decades, to talk about the epidemic as something that had not quite risen to the level of a major historical event. The third factor is the rapidity with which the cultural attention of the country moved on. The armistice of November 1918 gave Americans something very large and very positive to focus on. The war was over. The boys were coming home. The long national anxiety of the war years was resolving into something that felt, for a moment, like triumph. The cultural energy that had been organized around the war, the flag waving, the bond drives, the patriotic rallies, had nowhere obvious to go once the war ended, and some of it flowed into a kind of celebratory release that did not have much room for quiet reckoning with an epidemic. The 1920s, which followed almost immediately, provided an even more powerful distraction. The decade that would be called the Roaring Twenties was one of the most culturally dynamic periods in American history. Jazz, cinema, the automobile, consumer culture, social liberation, political controversy. There was a great deal happening, a great deal to engage with, a great deal of novelty and excitement and conflict. The epidemic that had just killed hundreds of thousands of people was simply not where the cultural energy of the 1920s wanted to be. The fourth factor, perhaps the most psychologically fundamental, is the nature of collective trauma and the human preference for forward motion. Psychologists studying collective responses to catastrophe have noted, consistently, that societies have a strong tendency to move forward rather than to dwell on traumatic events, particularly when the events are recent enough that dwelling on them is painful, when there is no external enemy to blame. The virus had no face, no nationality in any meaningful sense, no political identity, and when the narrative of the catastrophe offers no redemptive structure. The 1918 epidemic offered no redemptive narrative. It could not be framed as a victory. It could not be framed as a meaningful sacrifice. It could not be attributed to an enemy whose defeat would give the suffering purpose. It was simply a disaster, large, arbitrary, and medically humiliating, in the sense that the science of 1918 had been essentially helpless before it. There was nothing in the experience from which a comfortable national story could be made. Given all of this, the forgetting was not surprising. It was, in a way, almost inevitable. What is surprising, or should be, at this distance, is how complete it was and how long it lasted. For most of the 20th century, the 1918 pandemic was a topic in academic, medical, and public health literature, referenced by specialists, studied in comparative mortality analysis, mentioned in histories of the First World War, where it intersected with military operations. It was not a topic in the general culture. It did not appear in school curricula in any systematic way. the generation that had lived through it did not, for the most part, talk about it. Their children, the baby boomers, born in the late 1940s and 1950s, grew up largely without knowledge of it. And the generation after that knew it primarily, if at all, as a reference in the margins of history books. The rediscovery of the 1918 pandemic as a subject of broad public interest happened gradually in the 1990s and early 2000s, driven partly by academic work that was being published, partly by the emergence of new potential pandemic threats, including avian influenza strains that raised the question of whether something like 1918 could happen again, and partly by a cultural moment that was, perhaps, somewhat more willing to look backward at difficult things than the immediate post-war decades had been. By 2005, with pandemic preparedness discussions becoming more prominent in public health policy circles, 1918 had been substantially rehabilitated as a historical subject. Books were written, documentaries were made. The scientific work of reconstructing the 1918 virus from preserved specimens, a remarkable and somewhat controversial project that succeeded in the mid-2000s, brought the epidemic into the news in ways that connected the historical past to contemporary scientific reality. And then, of course, came 2020, and the generation that had never heard of 1918 suddenly knew exactly what it was. Here is something worth sitting with for a moment. The 1918 pandemic killed hundreds of thousands of Americans in conditions of medical helplessness. The physicians treating those patients could not identify the causative agent. They could not offer specific treatment. They could not reliably predict which patients would deteriorate and which would recover. They were, by the standards of what we now understand about the disease they were facing, essentially working in the dark. And yet, that experience of helplessness, that specific, documented, professionally and personally humiliating experience of being confronted with a catastrophic epidemic and having almost nothing useful to offer, produced, in the years and decades that followed, some of the most consequential developments in the history of American medicine and public health. The relationship between medical catastrophe and medical progress is not simple or automatic. Catastrophe does not guarantee learning. It does not guarantee that the lessons will be drawn correctly, funded adequately, institutionalized effectively. History is full of epidemics that were survived without producing lasting reform. But the 1918 pandemic was large enough, and the failures it exposed were clear enough, that it did produce change. Not immediately, not smoothly, but genuinely and durably over the years that followed. The most direct scientific legacy of the 1918 pandemic was the program of influenza research that it motivated. The question of what caused influenza, still unresolved in 1918, with the bacterial theory still dominant in much of the medical community, became, in the 1920s, a subject of intensive scientific investigation. The work of identifying influenza as a viral disease, and eventually of isolating and characterizing the influenza virus, was driven by researchers who understood, from the experience of 1918, that the question had implications far beyond academic interest. Richard Shope, working at the Rockefeller Institute for Medical Research, demonstrated in the early 1930s that swine influenza was caused by a filterable agent, meaning a virus rather than a bacterium. His work, combined with the contemporaneous work of Wilson Smith, Christopher Andrews, and Patrick Laidlaw in Britain, who isolated the human influenza virus in 1933, established the viral etiology of influenza on a solid scientific foundation. The 1918 pandemic had created the urgency that drove this research, and the research created the foundation on which subsequent influenza virology would be built. The isolation of the influenza virus made vaccine development possible, in principle. The first influenza vaccines were developed in the late 1930s and early 1940s, driven in part by military interest in preventing the kind of epidemic that had devastated military camps in 1918. The Army, which had watched its training camps become epidemic focal points during the fall of 1918, had a very direct institutional memory of what uncontrolled influenza could do to military readiness, and it was not inclined to repeat the experience if it could be avoided. The first large-scale influenza vaccine trials in the United States were conducted during the Second World War, involving soldiers as subjects. The results were sufficiently promising that influenza vaccination became part of the military health program and subsequently developed into the civilian vaccination programs that, in various forms, persist today. The development of influenza vaccines is not a straight line from 1918 to the present. It involved wrong turns, setbacks, scientific controversies, and the persistent challenge posed by a virus that mutates faster than most vaccines can track. The annual influenza vaccine formulation, updated each year to match the strains predicted to be circulating in the coming season, is itself a product of a global surveillance system that was built piece by piece across the 20th century, specifically to address the lesson of 1918, that you need to know what is coming before it arrives. The broader infrastructure of public health surveillance, the systems for monitoring disease incidents, identifying outbreaks, characterizing novel pathogens, and coordinating response across jurisdictions, was also shaped in important ways by the 1918 experience. The epidemic had revealed with unmistakable clarity how much was not being watched, how slowly information moved, how inadequate the existing mechanisms for identifying and responding to a novel epidemic were. The specific institutional development that addressed these gaps was slow and uneven, occurring across decades rather than in a single reform. But the trajectory is traceable. The expansion of state and local public health departments in the 1920s, the development of epidemiological methods, the systematic study of how disease spreads through populations as a recognized scientific discipline, the creation of the Communicable Disease Center in Atlanta in 1946, the organization that would eventually become the Centers for Disease Control and Prevention, with a specific mandate to track and respond to infectious disease threats at a national level. The CDC's founding is often attributed primarily to the malaria control work that preceded it, and that attribution is accurate. But the institutional memory of 1918 was part of the background against which post-war public health policy was made, and the argument that the United States needed a permanent, nationally coordinated infectious disease surveillance and response capability drew, implicitly and explicitly, on the lessons of what had happened when such a capability did not exist. The development of hospital infrastructure was another area where the 1918 pandemic left measurable institutional traces. The epidemic had overwhelmed hospital capacity in affected cities with a speed that exposed how thin the margin between adequate and catastrophically inadequate hospital capacity actually was. In the years following the epidemic, discussions of hospital planning began to incorporate more explicitly the concept of surge capacity, the ability to expand beyond normal operating levels during a crisis. This is a concept so embedded in contemporary hospital planning that it barely seems like a concept at all. In 1918, it was a lesson being learned in real time, at enormous cost. The nursing profession also changed in the aftermath of 1918 in ways that reflected both the heroism of nurses during the epidemic and the inadequacy of the systems that had supported them. The demand for trained nurses during the fall wave had far exceeded the supply, and the improvised solutions, rapidly trained volunteers, nurses working beyond the limits of endurance, emergency nursing schools producing graduates faster than proper training warranted, had exposed the fragility of a healthcare workforce that was not large enough, not well enough supported, and not adequately organized for a major emergency. The expansion of nursing education and the professionalization of nursing as a career in the 1920s and 1930s were not caused solely by the 1918 experience, but that experience was part of the pressure producing them. None of these changes happened quickly. None of them happened cleanly or without conflict and setback. Medical and public health reform in America has never moved in straight lines. It has always been entangled with economics, politics, professional interests, and the competing priorities of a large and diverse society. But the direction of movement, across the decades following 1918, was toward a more capable and better organized system for dealing with the kind of threat that 1918 had represented. The system that existed in 2020, the CDC, the state and local health departments, the hospital surge planning frameworks, the influenza surveillance networks, the vaccine development infrastructure, was not what it might have been if 1918 had been taken more seriously, more consistently, in the decades between. But it was considerably more than what had existed before 1918. The epidemic that killed hundreds of thousands of Americans in conditions of helplessness had, over the century that followed, motivated the construction of the tools that might prevent the next one from being as bad. Whether those tools were adequate, whether the century of building had produced something equal to the challenges it would face, is a question that was answered with considerable force and mixed results, beginning in early 2020. The relationship between government and disease in America before 1918 was genuinely limited, and understanding how limited it was helps clarify how much the subsequent century changed it. The federal government's role in public health in 1918 was primarily the responsibility of the Public Health Service, a relatively small agency whose main functions included quarantine enforcement at ports of entry, the inspection of arriving ships and immigrants for signs of infectious disease, and the provision of medical care to merchant seamen. Its mandate did not extend to domestic epidemic response in any systematic way. The federal government had no general authority to impose quarantine or other public health measures within states. Public health was, constitutionally and practically, a state and local matter. The states and cities had public health departments of varying capacity and varying seriousness. Some cities, New York notably, had developed relatively capable public health bureaucracies by 1918, with trained staff, laboratory capacity, and some experience with epidemic response from earlier outbreaks of typhoid, smallpox, and other diseases. Others had much less. Rural areas and smaller towns often had essentially no formal public health infrastructure. A farmer in rural Kansas in 1918 who became ill with influenza was dependent on whatever medical care existed within traveling distance, and on the informal support of family and neighbors, and on his own constitution. This patchwork, capable in some places, nearly non-existent in others, was what America had when the 1918 epidemic arrived. The inadequacy of this patchwork, demonstrated with such brutal clarity by the epidemic's progression through poorly prepared communities, was a powerful argument for something more systematic. The argument was heard eventually. Not immediately. The immediate post-war period was not a time of expanding government in America. The political mood of the early 1920s ran in the opposite direction, toward a reduction of the wartime government expansion and a return to what Warren Harding famously called normalcy. The appetite for new federal programs and new federal authority was limited. But the pressure of demonstrated need does not disappear simply because the political moment is unfavorable to acting on it. The evidence of what inadequate public health infrastructure had cost in 1918 remained in the records, in the memories of the physicians and public health officials who had experienced it, in the institutional knowledge of the organizations that had tried to respond. And gradually, across the 1920s and 1930s and 1940s, that evidence produced changes. State health departments expanded, in most states, through the 1920s. The number of trained public health officers, physicians with specific training in epidemiology and public health administration, grew. The development of public health as an academic and professional discipline centered in schools of public health that began to be established at major universities in the early 1920s, created a trained workforce that had not previously existed in sufficient numbers. Johns Hopkins University established its School of Hygiene and Public Health in 1916, just before the epidemic. But the epidemic made the case for what that school was doing more powerfully than any peacetime argument could have. Harvard established its own school in 1922. Other universities followed. These institutions produced the epidemiologists, the biostatisticians, the public health administrators, and the health educators who would staff the expanding public health apparatus over the following decades. The federal role in public health expanded more slowly and against more political resistance than the state and local role. The constitutional questions about federal authority in public health matters were not trivial, and the political culture of the 1920s was not hospitable to arguments for federal expansion in domestic affairs. But the federal government did expand its public health activities across the interwar period. Through the Public Health Service's growing research and regulatory functions, through the Social Security Act of 1935, which included provisions for federal grants to states for public health programs, and through a gradual accumulation of precedents and authorities that made a more active federal role in public health increasingly normalized. The Second World War accelerated this process, as wars tend to accelerate government expansion in almost every direction. The wartime federal government's engagement with public health, through the military medical system, through industrial health programs in war production facilities, through the malaria control operations in the American South that would seed the eventual CDC, created institutional capacities and precedents that were not fully dismantled after the war ended. The CDC's founding in 1946 represents, in some ways, the institutional crystallization of lessons that had been accumulating since 1918. Not the direct or immediate product of the 1918 pandemic, the institutional lineage is more complex than that, running through malaria control and wartime military medicine, but shaped, at some level, by the understanding that infectious disease threats require a permanent, coordinated national response capability. That understanding was, in turn, partly grounded in the memory of what it had cost to face a major epidemic without one. The public health state that exists in contemporary America, the CDC, the state and local health departments, the regulatory frameworks for food and drug safety, the surveillance systems for infectious disease, is an institutional legacy of a century of lessons learned, some of them from 1918, many of them from the diseases and crises that followed. It is imperfect, underfunded in many of its components, subject to political pressure in ways that the scientists who operate within it find perpetually frustrating. It is also, compared to what existed in 1918, an extraordinary achievement. The question that 2020 forced Americans to confront, whether that achievement was adequate to the challenges of the present, is one on which reasonable people continue to disagree. The 1920s began, in the cultural imagination of the United States, as the decade after the war. The decade of returned soldiers and victory parades and the resumption of civilian life. The decade of jazz and flappers and speakeasies and the Model T. The decade that F. Scott Fitzgerald would capture and mythologize and ultimately eulogize. What the 1920s rarely appear as, in either popular or academic history, is the decade after the epidemic. The decade in which the survivors of the 1918 flu, all of the survivors, the entire adult population of the United States, were living out whatever came next. The decade in which the orphans of the epidemic were growing up. The decade in which the families that had lost fathers and mothers and siblings were reconstituting themselves in whatever shape was still possible. The relationship between the epidemic and the cultural character of the 1920s is one of the more genuinely interesting and genuinely uncertain questions in American cultural history. The correlation is clear enough. The epidemic ended, the Roaring Twenties followed, but correlation is not causation. And attributing specific cultural developments to the psychological legacy of a pandemic is a treacherous analytical move. And yet, the appetite for pleasure and distraction that characterized 1920s American culture, the jazz clubs, the dance halls, the cocktail parties, the consumer culture explosion, the enthusiasm for novelty and sensation, is not nothing. It does not emerge from nowhere. And a population that has just been through several years of wartime sacrifice, followed immediately by a catastrophic epidemic, a population that has lost hundreds of thousands of its members to disease and further hundreds of thousands to combat, a population that has been told for years to be sober and patriotic and controlled and forward-looking. That population has, it seems reasonable to suggest, accumulated a considerable appetite for the opposite of all of those things. Historians have debated the specific relationship between the 1918 pandemic and the cultural explosion of the 1920s with considerable care and appropriate scholarly caution. The war is always present in these discussions, and the war's influence on post-war culture is so well documented and so extensively analyzed that it is hard to isolate the epidemic's specific contribution. The two catastrophes overlapped in time and in their effects on the population, and disentangling their respective legacies is genuinely difficult. What some historians have argued, with evidence that is suggestive rather than conclusive, is that the particular quality of 1920s pleasure-seeking has the character of something responding to mortality in a fairly specific way. Not the pleasure of people who have never been frightened, but the pleasure of people who have recently been very frightened and are now, with some desperation, insisting on its opposite. The parties in Fitzgerald's fiction are not simply enjoyable. They have an edge to them, a slightly hectic, slightly hollow quality that the characters themselves sometimes recognize and cannot quite escape. Whether that quality reflects the war, the epidemic, or some combination of both, whether it reflects the experience of loss and mortality more broadly, regardless of specific cause, is a question that literature and cultural history can approach but not definitively resolve. What seems clear is that the 1920s were not simply the celebration of people who had survived and were grateful. They were something more complicated, something in which the pleasure and the grief were entangled in ways that the participants probably did not fully understand, and that the historians who have examined them since have struggled to fully articulate. The speakeasies of the Prohibition era, the illegal drinking establishments that proliferated after the 18th Amendment took effect in 1920, are usually discussed in terms of the politics and economics of prohibition, the rise of organized crime, the cultural rebellion against Puritan morality. Less often discussed is the simple human fact that people who have been through several years of collective suffering have a strong inclination to drink together, in rooms where the music is too loud for thinking. That inclination is not unique to the 1920s. It is very old, but the particular form it took in that decade, and the particular intensity with which it was pursued, was shaped by the specific experience of that generation. The African-American cultural renaissance that flourished in the 1920s, the Harlem Renaissance, with its extraordinary flowering of literature, music, visual art, and political thought, was also not unconnected to the epidemic's aftermath. The Great Migration, which brought hundreds of thousands of Black Americans from the rural South to the urban North in the years surrounding the First World War, had been partly motivated by the labor opportunities created by the wartime industrial expansion. The epidemic had moved through those newly arrived northern communities with particular severity, given the overcrowded housing conditions and limited healthcare access. The artistic and intellectual explosion of the Harlem Renaissance in the 1920s emerged from a community that had experienced, in the preceding years, both the possibilities of northern urban life and its very real dangers and limitations. The Harlem Renaissance is generally understood in terms of the cultural politics of Black American identity, the Great Migration, and the contradictions of a democratic society that practiced systematic racial exclusion. The epidemic is rarely part of that story, even though the community that produced the Renaissance was a community that had been through it, in specific and often severe ways. The 1920s were, in sum, more complicated than the roaring label implies. They were exuberant and sad, liberated and haunted, forward-looking, and somehow always running from something. The epidemic is part of what they were running from, even if nobody at the time would have described it that way. The mass death of working-age adults during the 1918 pandemic had economic consequences that were real, measurable, and in some ways counterintuitive. The most immediate and straightforward economic consequence was labor scarcity. When a significant fraction of the working-age population dies within a short period, the supply of labor decreases. Basic economics suggests that when supply decreases and demand remains constant, price increases. In the context of labor markets, that means wages. The years immediately following the 1918 pandemic did see upward pressure on wages in a number of industries, driven by a combination of the labor force losses from the epidemic and the related disruptions of the post-war demobilization. Workers who survived, who were available, healthy, and capable of employment, found themselves in a labor market that was somewhat more favorable to them than the pre-war market had been. The bargaining position of labor relative to capital shifted, at least temporarily, in ways that reflected the changed supply of available workers. This dynamic was, of course, entangled with a great many other post-war economic developments. The return of demobilized soldiers to the civilian labor market, the transition from wartime to peacetime industrial production, the commodity price fluctuations of the early 1920s, and the political pressures on organized labor that intensified in the Red Scare atmosphere of 1919 and 1920. Isolating the epidemic's specific contribution to post-war labor market dynamics is analytically difficult, and economists who have attempted it have produced findings that are interesting but hedged with appropriate uncertainty. What is clearer is the epidemic's impact on specific occupational categories in specific communities. In towns and industries where the epidemic had been particularly severe, where the death rate among working-age men had been high relative to the available workforce, the labor shortage was not a statistical abstraction. It was a practical problem that affected the ability of farms to be harvested, mines to be worked, factories to be operated. Some employers in severely affected communities reported genuine difficulty finding sufficient workers in the months and years following the epidemic. And some of those employers responded, as economic theory would predict, by offering higher wages or better conditions to attract and retain the workers they needed. The epidemic's economic legacy also ran through the consumer side of the economy. The deaths of primary earners in hundreds of thousands of families reduced the consumption capacity of those families for years afterward. A household that loses its primary earner to influenza and does not find a way to replace that income. And in 1918, without the social safety net that would be constructed over the following decades, many did not, is a household that buys less. That reduction in consumer demand, distributed across a large number of affected households, had macroeconomic consequences that were real, even if they are difficult to separate from the many other economic disruptions of the post-war period. The economic recovery of the early 1920s, the prosperity that preceded the Depression, and that is associated, in popular memory, with the boom of the Roaring Twenties, has been analyzed primarily in terms of post-war industrial restructuring, the expansion of consumer credit, the automobile industry's growth, and the policies of the Harding and Coolidge administrations. The epidemic's economic legacy, the labor market shifts, the household income losses, the distributional consequences of age-specific mortality, is less present in these analyses than it might be, for the same reason that the epidemic is less present in most historical analyses of the 1920s. It was not, for most of the 20th century, what historians were looking for: the economic experience of specific communities, the small towns where the epidemic had been severe, the mining districts and farming communities where the labor force losses had been acute, was, in some cases, genuinely difficult in the years following the epidemic. The recovery was uneven, both geographically and by sector. The prosperity of the 1920s, real as it was in the aggregate, was not uniformly distributed. Some communities were still working through the economic consequences of their pandemic losses years into the decade. This unevenness, the gap between the aggregate prosperity of the 1920s and the experience of specific communities that had been particularly hard hit, is one of those historical details that gets lost when history is told at the national level. The Roaring Twenties roared louder in some places than in others. In some of those places, the reason they roared less had something to do with what had happened in the fall of 1918. There is a particular kind of historical weight that settles on a story when you reach its final chapter. Not the weight of conclusion. History rarely concludes in the satisfying sense that stories do, but the weight of recognition. The feeling of having followed something far enough that you can now turn around and see the whole of it, or at least more of it than you could at the beginning. We have followed the 1918 pandemic from the crowded streets of a country at war, through the catastrophic fall wave, through the uneven and painful process of surviving it, through the institutions and cultural movements that emerged from its shadow. We have watched a country lose hundreds of thousands of its people and then, with a speed that still seems almost impossible, find ways to stop looking directly at what it had lost. What remains are the longer threads, the ones that didn't resolve in the 1920s or the 1930s or even the 1940s, the ones that ran forward through the century in ways that were not always visible, that connected the specific catastrophe of 1918 to the specific world that came after it, sometimes in ways that could be traced, sometimes in ways that could only be inferred. These are the threads worth following to the end, not because they produce comfortable conclusions, but because they are true, and because the truth of them matters more now than it has at any point in the century since the epidemic ended. The children who lost parents to the 1918 pandemic occupy a strange position in the historical record. They were numerous. By some estimates, tens of thousands of children were left without one or both parents by the epidemic, though the precise figure is impossible to establish with confidence from available records. They were young enough, in many cases, to have their entire subsequent development shaped by what the epidemic had taken from them. And they are, as a group, almost entirely absent from the historical narrative of the period. This absence is not entirely surprising. The mechanisms by which historians learn about the inner lives of ordinary people, through diaries, letters, memoirs, oral histories, are less available for children than for adults, and considerably less available for poor children than for wealthy ones. The orphans of 1918 were, by definition, children who had lost the adults most likely to document their experiences and advocate for their visibility in the historical record. They were, in many cases, absorbed into the informal support structures of extended family and community, their specific circumstances neither tracked by government nor recorded in institutional histories. Some went to relatives, grandparents, aunts and uncles, older siblings who had themselves just reached adulthood. These arrangements were made quickly, out of necessity, without formal processes, and left few traces in the documentary record. Whether those arrangements were adequate, whether the children within them were cared for and loved and given reasonable opportunities, varied enormously depending on the specific family circumstances, the economic resources of the relatives who took them in, and the particular characters of the people involved. Some went to orphanages. The institutional records of orphanages from the 1919 to 1922 period, in cities and regions most severely affected by the epidemic, show elevated intake numbers that reflect the pandemic's orphaning effect. The quality of care in those institutions varied widely. Some were run by religious organizations with genuine commitment to child welfare and reasonable resources. Others were overcrowded, underfunded, and not, by any standard that would be recognized today, adequate environments for children to grow up in. The orphanage system in America in the early 20th century was itself in a period of transition and debate. Child welfare reformers, active since the late 19th century, had been arguing for alternatives to institutional care, for systems of foster placement and family support that would keep orphaned or abandoned children in family environments, rather than institutional ones. The first White House Conference on the Care of Dependent Children, held in 1909 under Theodore Roosevelt, had produced a declaration that children should, where possible, be raised in families rather than institutions. The implementation of this principle was slow and uneven, But the direction of child welfare policy was moving toward what would eventually become the modern foster care system. The epidemic of 1918 added pressure to this transition by adding children to the system faster than the existing institutional infrastructure could comfortably absorb them. The response varied by state and city. Some jurisdictions expanded their orphanage capacity. Some made greater use of informal foster arrangements. Some, particularly those with active child welfare organizations, attempted to match orphaned children with families through emerging placement systems. What happened to those children, in the long run, is a question that has not been systematically studied. The data linkage that would allow historians to identify a cohort of 1918 pandemic orphans and trace their subsequent life trajectories, their educational outcomes, their economic mobility, their health, their family formation patterns, has not been done in any comprehensive way. The records that would enable it are scattered across state archives, institutional records, and county courthouse files, in forms that are difficult to aggregate and analyze. What we can say, with reasonable confidence, is that losing a parent in childhood, particularly the primary economic provider of a family, in a period without the social support structures that would develop over the following decades, had consequences that extended well beyond the immediate crisis. Children who grew up in poverty because a parent's death had removed the family's income were children with reduced access to education, reduced nutrition, reduced health care, and reduced opportunities. The epidemic did not create those structural disadvantages. It took children who were already vulnerable to them and made them more so. The orphans of 1918 grew up, in most cases, without anyone acknowledging specifically what they had been through. The culture around them did not provide a framework for being a pandemic orphan in the way that it provided, however inadequately, frameworks for being a war orphan. There were no organizations dedicated to their welfare as a specific category. There were no recognition ceremonies, no public acknowledgments of their specific loss. They were simply children who had lost parents, added to the category of children who had lost parents for various reasons, and managed as best as circumstances allowed. Some of them, undoubtedly, thrived. Some built successful lives and raised families, and grew old without the absence of 1918 defining them. Some did not. The range of outcomes was as wide as the range of circumstances into which they were born and in which they were raised. This is not a comforting conclusion. It is simply an honest one. The American soldiers who returned from France in the months following the November 1918 armistice came home to a country that had, in their absence, been through something they had not been part of. This is a strange thing to sit with. The men who went to France to fight the war, and who had their own catastrophic encounters with epidemic influenza in the military camps and in the trenches, where the flu had also been devastating, came home to find that the home front had its own epidemic story, one that had unfolded in their absence, in the communities they had left behind. Some came home to find family members dead. A letter arriving in France might have told them that a parent, a sibling, a wife, a child had died of influenza while they were overseas. Some received no warning and discovered the loss only on arrival. The intersection of war grief and epidemic grief in the experience of returning veterans was a combination that the support systems of 1919 were entirely unprepared to address, partly because those support systems were minimal by any subsequent standard, and partly because the combination itself, a man grieving both the friends he had lost in combat and the family members he had lost to disease simultaneously, did not fit neatly into any available category. The veterans returned to a country that was simultaneously celebrating victory and quietly processing an enormous amount of loss. The emotional register of the homecoming was, depending on where you were and what had happened to your family, somewhere between genuine joy and a kind of hollow relief. The soldiers were alive. The war was over. The epidemic had killed more Americans than the war had, and most of the celebratory homecoming narratives found ways to not acknowledge this simultaneously. The reintegration of veterans into civilian life in 1919 was difficult in ways that had little to do with the epidemic specifically, but that were not improved by the epidemic's legacy. The men returning from France had been changed by what they had seen and done. Many of them were carrying what we would now recognize as post-traumatic stress, then called shell shock or neurasthenia, or various other terms that reflected an incomplete understanding of the condition, without any systematic treatment or support. The mental health resources for returning veterans in 1910 were, by contemporary standards, essentially non-existent. They returned to a labor market disrupted by the post-war transition, to communities that had in some cases been significantly altered by the epidemic, to families that had in some cases been broken by it. The adjustment was, for many, arduous. The transition from military service to civilian life is rarely easy under any conditions. Under these conditions, it was particularly hard. The political disillusionment of veterans was a significant feature of the early 1920s in America. The idealism with which American involvement in the war had been promoted, Woodrow Wilson's rhetoric of making the world safe for democracy, of a war to end war, had collided with the grim reality of what the war had actually been, and with the perceived failure of the subsequent peace to deliver what had been promised. The Treaty of Versailles, the Senate's rejection of the League of Nations, the sense that the sacrifices had not produced the better world they had been meant to produce. These produced a disillusionment in the veteran population that fed into the broader cultural mood of the 1920s. The epidemic added another layer to this disillusionment. Veterans who had seen the government manage information about the epidemic dishonestly, who had watched military camps become epidemic killing grounds partly through decisions made by people who prioritized military readiness over soldiers' health, who had perhaps lost family members to the epidemic while they were overseas and unable to do anything about it. These veterans had specific reasons, grounded in specific experiences, to be skeptical of official assurances and governmental competence. The erosion of trust in institutions that characterized American political culture in the 1920s, the skepticism about government, the cynicism about public figures, the withdrawal from civic engagement that some historians have documented for this period, was not caused by the epidemic alone. But the epidemic contributed to it, in ways that are not always recognized because the epidemic itself has been missing from the historical narrative. The bonus marchers of 1932, the veterans who gathered in Washington to demand early payment of the service bonuses promised to First World War veterans, and who were forcibly dispersed by the Army under orders from the Hoover administration, were, among other things, men who had spent the preceding decade watching the promises made to them fail to materialize. Some of them had been through the epidemic as well as the war. Their grievances were economic and political, rooted in the specific circumstances of the Depression. But they were also men who had learned, over a decade and a half, to expect less from the government than the government had promised them. Their story, and the stories of the veterans who came home in 1919 to a country that was simultaneously changed and in deep denial about how it had changed, are part of the epidemic's legacy, a part that has rarely been told in connection with the flu, but that belongs there. Trust is one of those things that is very easy to take for granted until it erodes, and very difficult to rebuild once it has. The 1918 pandemic damaged trust in American institutions, in government, in medical authority, in the public information systems through which citizens were supposed to understand what was happening to them, in ways that were real and that persisted in various forms for years afterward. The damage was not uniform. Different communities and different individuals had different experiences of the official response and drew different conclusions from those experiences. But the pattern of information management during the epidemic, the downplaying of severity, the delayed warnings, the contradictory public health guidance, the gap between what officials knew and what they told the public was visible enough in retrospect that it did not go entirely unremarked. People in cities like Philadelphia, who had been told that the epidemic was under control in the days before the September parade, and then watched their hospitals fill and their neighbors die within a week of that reassurance, had been given specific and personal reasons to doubt official reassurances. They had experienced, in the most direct possible way, the consequences of a gap between what authorities said and what was actually true. That experience does not produce, in most people, an increased confidence in the reliability of official communication. The medical profession also took a reputational hit from the epidemic, though a more complicated one. Physicians had been helpless before the epidemic in ways that were, to the patients and families they were failing, visible and sometimes bewildering. People had seen doctors arrive at bedsides, do very little, and leave without having prevented death. They had seen the treatments recommended, the bacterium vaccines that turned out to be ineffective, the various folk and medical remedies that circulated during the fall wave prove useless. They had encountered, in some cases, physicians who were themselves sick or dead. The confidence in medical authority that had been growing in the late 19th and early 20th centuries as medicine became more clearly a scientific, rather than merely a credentialed enterprise, was shaken by the epidemic's demonstration of how much medicine still didn't know. This is a nuanced point. The epidemic did not, in most communities, produce a wholesale abandonment of faith in medicine. The development of effective vaccines, antibiotics, and other medical technologies in the subsequent decades generally increased public confidence in medicine over the long run. But the epidemic did leave, in communities that experienced it most severely, a residue of skepticism, a memory, carried in family stories and community knowledge, that doctors did not always know what they were doing, and that official reassurances were not always reliable. That residue of skepticism sometimes showed up in unexpected ways in the following decades. The resistance in some communities to public health interventions, vaccination campaigns, quarantine measures, official health recommendations, cannot be attributed solely to the experience of 1918. These phenomena have multiple causes, rooted in different communities' different historical relationships with medical and government authority. But the 1918 experience is part of the background for some of that resistance, particularly in communities that had specific and well-founded reasons to distrust official health management. The information suppression of the wartime period also left a more specific and traceable institutional legacy. The Espionage and Sedition Acts that had enabled the wartime censorship regime were repealed or allowed to lapse after the war, and the most aggressive surveillance of public speech was wound down in the early 1920s. But the experience of operating under wartime information management of knowing that the press was not fully reporting what was happening, that official statements were calibrated for morale rather than accuracy, was an experience that shaped the relationship between American citizens and their information environment in the years that followed. The press itself drew some lessons from the episode, though the lessons were not uniformly applied. The American newspaper industry of the 1920s was not dramatically more committed to reporting uncomfortable truths than it had been in 1918. The structural pressures that had shaped epidemic coverage, the relationships between newspaper publishers and the government, the commercial incentives not to alarm advertisers, the professional culture of the era, did not disappear because the war ended. But the memory of having been demonstrably inadequate in its coverage of a major national crisis was not entirely without effect on how some journalists and editors thought about their professional responsibilities. The legacy of 1918 for American trust is, in the end, mixed and difficult to disentangle from the many other forces shaping trust in the 20th century. What seems clear is that the epidemic contributed to the landscape of uncertainty and skepticism that characterized American public life in the 1920s and beyond, and that the specific mechanisms of that contribution, the information management, the institutional failures, the gap between official communication and reality, are recognizable to anyone who has paid attention to the debates about trust, media, and government that have characterized American public life in the years since. The 1918 influenza virus did not simply disappear when the pandemic ended. Nothing in virology works quite that simply. What happened instead was a process of viral evolution and persistence that is still being studied and that connects the pandemic of 1918 to the influenza seasons of every subsequent year through a lineage of viral descent that is genuinely remarkable to contemplate. The H1N1 influenza subtype that caused the 1918 pandemic circulated in the human population for decades after the pandemic ended, evolving as influenza viruses always do, through a process of continuous mutation that gradually changes the virus's surface proteins in ways that allow it to partially escape the immunity built up by previous infection. Each year's influenza season is, in a sense, another chapter in the story of viral evolution that began with the emergence of the 1918 strain, or whatever predecessor strain gave rise to it. The pandemic of 1957, the Asian flu, was caused by a new influenza subtype, H2N2, that replaced the descendant H1N1 strains that had been circulating since 1918. The 1968 pandemic, the Hong Kong flu, brought yet another new subtype, H3N2. These subsequent pandemics were serious. The 1957 pandemic killed an estimated 1 to 2 million people globally. The 1968 pandemic, a similar number. But neither approached the catastrophic mortality of 1918. The reasons for the lower mortality of subsequent pandemics are not entirely clear and probably involve multiple factors. The populations exposed to the 1957 and 1968 pandemics had some degree of prior immunity to influenza, even if not to the specific new subtypes. Medical capabilities had advanced considerably. Antibiotics could now treat the secondary bacterial pneumonias that had killed many 1918 flu patients. And hospital care had improved in ways that improved outcomes for severely ill patients. The viruses themselves may have been intrinsically less lethal than the 1918 strain, for reasons related to their specific biological properties. The H1N1 subtype made a dramatic and unsettling return in 2009, when a new H1N1 virus, carrying genes derived from swine, avian, and human influenza strains, emerged and caused a pandemic that spread globally with considerable speed. The 2009 H1N1 pandemic attracted enormous attention from public health authorities, partly because its subtype, H1N1, the same as 1918, triggered specific historical anxieties. If the 1918 pandemic had been H1N1, might a new H1N1 strain carry similar pandemic potential? In the event, the 2009 pandemic was considerably less severe than 1918. The reasons were multiple. The population had some residual immunity to H1N1 from prior seasonal influenza circulation. A vaccine was developed and deployed with a speed that would have been impossible in 1918. The medical infrastructure for managing severe influenza, antivirals, intensive care units, mechanical ventilation, was vastly better than anything available 9 decades earlier. The final death toll of the 2009 pandemic, while significant, was orders of magnitude lower than 1918. But the 2009 experience reminded public health authorities of something they already knew intellectually, but that the intervening decades of relative pandemic quiet had perhaps allowed to fade from urgency. That pandemic influenza remained a genuine threat. That the 1918 event was not a historical curiosity, but a template for a class of threat that could recur, and that the world's pandemic preparedness systems needed to be maintained and improved rather than allowed to atrophy. The scientific work done on the 1918 virus in the late 20th and early 21st centuries is one of the more extraordinary episodes in the history of virology. Jeffrey Taubenberger and his colleagues at the Armed Forces Institute of Pathology spent years attempting to recover genetic material from preserved specimens of 1918 influenza victims, from archived lung tissue samples, and ultimately from the body of an influenza victim preserved in the permafrost of Alaska. A woman named Lucy Osceola, who had died in November 1918, and whose body had been frozen in the Alaskan ground ever since. The project succeeded. By 2005, the complete genome sequence of the 1918 influenza virus had been reconstructed and published, and a group at the CDC led by Terence Tumpy had recreated the virus from synthetic genetic material in a biosafety laboratory setting. The recreated 1918 virus was, in laboratory testing, extraordinarily virulent, confirming the historical mortality data and providing a molecular basis for understanding why the 1918 pandemic had been so devastating. The experiment also provided a foundation for research into vaccines and antivirals specifically designed to address 1918-like viral threats, contributing to pandemic preparedness planning in ways that would not have been possible without the molecular knowledge the reconstruction provided. The project was controversial. Recreating one of the deadliest viruses in human history raised biosecurity concerns that some scientists and biosecurity experts considered serious. And the debate about its wisdom has continued. But it represents, in its own way, the culmination of a century of scientific effort to understand what happened in 1918. The virus that killed hundreds of thousands of Americans in conditions of total medical helplessness was, by 2005, an organism whose genome was fully known and whose properties could be studied in a controlled setting. The science that the epidemic had ultimately motivated had, a century later, achieved something genuinely remarkable. What it had not achieved was a guarantee that the next pandemic would be manageable. Science advances. Viruses evolve. the relationship between human preparedness and viral threat is not a problem that gets solved. It is a problem that gets managed continuously, with varying degrees of adequacy. It is difficult, at this distance, to fully imagine what it felt like to be an ordinary American in the spring of 1920. Not a public health official, or a politician, or a scientist. Just an ordinary person, living in an ordinary community, doing ordinary things, in the aftermath of everything that had happened over the preceding several years. You had, in all likelihood, lost someone. Perhaps several people. Perhaps you had been seriously ill yourself, and had recovered in the way that most people recovered, slowly, with a fatigue and a lingering vulnerability that could persist for weeks or months after the acute illness passed. Perhaps you had nursed a family member through the illness, had sat by a bedside in the frightening way that bedside sitting in serious illness always is, and had experienced either the relief of recovery or the grief of loss. And now, what? The war was over. The epidemic was winding down, receding from the acute emergency of the fall of 1918 into something that felt, if not safe, then at least more manageable. Life was resuming. The businesses were reopening. The schools were taking children back. The social fabric, torn in places, was being mended with whatever thread was available. The impulse to move forward, to put the worst of it behind you, to focus on what was possible rather than on what had been lost, is entirely understandable and entirely human. It is, in many ways, the necessary response to catastrophe. You cannot live indefinitely in the acute phase of grief. You have to find a way to go on. The people who went on in 1920 and 1921 and the years that followed were not weak or dishonest for doing so. They were survivors, doing what survivors do. What they perhaps did not do, what the culture around them actively discouraged them from doing, was to stop and look back and say, "This happened. This terrible thing happened to us. And we should understand it, and remember it, and draw from it whatever wisdom it contains, so that the people who come after us are better prepared than we were." That reckoning did not happen. Not in the 1920s. Not really in the following decades. When it began to happen, in the early years of the 21st century, it was happening at a distance of 80 years or more from the events themselves, driven by researchers working from archives rather than from living memory, because the living memory was gone. The absence of that reckoning had costs. The costs were not immediately visible, and they accumulated slowly over decades in ways that did not announce themselves as consequences of the 1918 forgetting. But they were there, in the public health infrastructure that remained underfunded relative to the threat it was meant to manage. In the pandemic preparedness plans that were written and then allowed to sit on shelves. In the public trust deficit that made it harder, in subsequent crises, to communicate clearly and be believed. In the collective memory gap that meant that when a new pandemic arrived in 2020, millions of Americans had no reference point, no inherited wisdom, no sense of having been through something like this before, because the experience of having been through something like this before had been systematically and thoroughly forgotten. The 2020 pandemic rediscovered 1918 with something close to desperation. Suddenly, The academic literature on the Spanish flu was being cited in newspaper articles and policy briefings and public health communications. The St. Louis versus Philadelphia comparison was being discussed on television. The debates about school closures and business restrictions and mask mandates were being explicitly connected to what had happened and what had worked and what hadn't worked in 1918. The forgotten history was being rapidly retrieved, dusted off, and pressed into service. It was useful, genuinely useful. The 1918 data and the 1918 experience informed policy decisions in 2020 in ways that probably saved lives. But there was something bittersweet about the retrieval, because the knowledge had been available all along. The lessons of 1918 had been sitting in the archives, in the public health literature, in the careful academic work of a relatively small number of researchers who had spent decades arguing that this history mattered. The urgency that made people listen in 2020 had not existed before 2020, or not strongly enough. There is a lesson in that somewhere. Not a comfortable one, and not one that lends itself to easy summarization. Something about the relationship between collective memory and collective preparedness. Something about the cost of forgetting. Something about the difference between knowing something in principle and having it available in practice, when the moment comes. The 1918 pandemic changed America in ways that are real, even when they are difficult to trace. It changed the medical institutions and the public health systems and the research priorities and, gradually, the governmental structures through which the country manages its relationship with infectious disease. It changed the communities that lost the most from it, in ways that were felt for decades in those communities, even when they were not formally acknowledged. It changed the generation that lived through it, shaped the emotional landscape of the 1920s, contributed to the disillusionment of the veterans, left marks on the children who grew up in the absence of parents the epidemic had taken. And it changed the relationship between Americans and the idea of institutional trust, the confidence, or lack of it, that ordinary people have in the ability and willingness of their government and their medical establishment to tell them the truth and manage a crisis competently. That change was not the epidemic's only doing, but the epidemic was part of it, and the part it played has rarely been fully acknowledged. The Spanish flu was not a Spanish story. It was not a European story. It was an American story, one that happened here, to people who lived here, in communities that still exist, in a country that is still, in various ways, living in its aftermath. The marks it left are real. They are just quieter than the marks that get commemorated. There are no monuments to the 675,000 Americans who died of influenza in 1918 and 1919. No national memorial, no annual day of remembrance, no school curriculum that treats the epidemic as a foundational event in American history in the way that the Civil War or the Second World War is treated. The people who died left the same kind of absence that all deaths leave. The empty chairs, the unmade futures, the children who grew up with a specific shape of loss in their lives. They just left it without anyone building something to remember them by. Perhaps that is the final thing worth saying. Not as an accusation. The people who forgot were doing what people do, and the forces that produced the forgetting were real and understandable. But as a simple observation, they were here. They lived ordinary lives in ordinary American places. They got sick in a fall that was also a war, in circumstances that gave them almost no protection and almost no useful medicine. They suffered in the specific way that the 1918 influenza caused suffering, which was severe and quick, and, for those who died, complete. They were buried by families who grieved them, in communities that felt their absence for years, in a country that eventually, too quickly, too thoroughly, moved on. They deserved to be remembered. Most of them weren't. The least we can do, at this distance, is know that they were there. That the fall of 1918 happened. That the empty chairs were real. That the silence that followed was not the absence of a story, but the deliberate and understandable and costly suppression of one. And that knowing the story, even now, even at this remove, is not nothing. It is, in fact, the only thing that makes the forgetting mean something other than simply loss. The morning after the long night, in the spring of 1920, ordinary Americans woke up and made breakfast and went to work and raised their children and did all the things that ordinary people do, in the aftermath of things that should not have been survived but were. They were tired. They were changed. They were, most of them, ready to look forward. That is a human impulse so old and so deep that it barely needs explaining. The sun came up. Life continued. The world, as it always does, kept going. But the night had been very long and very dark. And it is worth remembering, even now, that it happened.